Good afternoon, everyone. I'm Matthieu Schmidt. I'm assistant professor in Paris, in Pitié-Salpêtrière Hospital. And we have 12 minutes together to discuss if ECMO has been under or overused during this COVID-19 pandemic. So here are my disclosures, not strictly related to the talk. So first of all, it's quite complicated to know what is the current incidence of ECMO use in severe ARDS in Europe. So for that, we can try to have some information from the LungSafe study showing that ECMO was roughly used in 3% of all ARDS patients, and if we focus on the severe ARDS patient, we see that ECMO was used in roughly 6% of that population. But this incidence was probably quite low in this cohort, where the main message was to say that ARDS was under-recognized. So probably we may expect a higher incidence of use of ECMO use. And also this incidence of ECMO use may vary from one country to another. In France, it's roughly 1 ECMO for 100,000 inhabitants. In Sweden, it's lower. In Germany, where ECMO is much more available, the incidence might be higher. And what is important to know and to retain before focusing on the COVID-19 is that the outcome of ECMO patients strictly depend on the experience of the centers. So clearly it has been shown in neonates, in pediatric, and also in adults that there is a direct relationship between the case volume, ECMO case volume, and the outcome at the end. So early on in the COVID-19 pandemic, experts in the field have stressed out that ECMO might play a key role in the management of severe ARDS during this crisis. And they advocate for a regional planning for ECMO allocation, to have a provision of ECMO services, and to be prepared for this pandemic. But in the beginning of the pandemic, we saw a mistrust regarding ECMO, and one example of that is the large cohort from the Lombardy region in Italy, which was strictly hit by the COVID-19 early on. And this region have many ECMO centers very active in the field. And we can be surprised that ECMO was only used for only 1% of that population, despite a very severe population with 88% population required endotracheal intubation and quite a high level of PEEP. And it was the same for the cohort from New York, reporting only 3% use in ECMO early on in the pandemic. So there are several explanations for VV ECMO underused, especially early on in the pandemic. First of all, it was a new disease with unknown outcome. Most of the health system were rapidly overwhelmed with, in some places, scarce resources in time of high demand. And also, we can maybe guess that people were expecting a long ICU stay for this ECMO patient. And it was quite tricky, complicated to allocate ECMO in this patient when ICU beds were already lacking because caregivers maybe were afraid of bed blockers with uncertain outcomes. Another explanation for VV ECMO underuse at the beginning of the pandemic was the large diffusion of anecdotal evidence, personal viewpoint, and large diffusion on all that viewpoint on social media without any clear scientific evidence, One example, it's this viewpoint published in a very good journal, Lancet Respiratory Medicine, saying that we should be worried, we should have caution for using ECMO with COVID-19, because ECMO were used to increase the inflammatory syndrome due to the extracorporeal device, and for that reason, because COVID-19 was mediated by EL6 concentration, he said that probably ECMO might be deleterious in that context. But it was not supported by any recent experience, recent evidence, and it was mainly driven by old studies. And in clinical practice, clearly, it was never an issue on ECMO, and clinical practice, we mainly see patient improving and being stabilized with ECMO. Another anecdotal evidence at the beginning of the pandemic, which concurred to underused ECMO, was the risk and the fear for health caregivers to have SARS-CoV-2 scavenging. And some news were coming from China saying that the small virus was able to cross the membrane oxygenation and to leaks and to aerosolize, to diffuse in the room some virus. So with a high risk for healthcare workers. In that study, when we look for a virus on 27 patients in the outlet of the oxygenator, on the oxygenator side, we never find virus extraction on that part, even in patients who were viremic. So clearly, it was not a strong information. It was maybe an anecdotal information without strong evidence. Another reason for VV ECMO underused was the initial alarm about the outcome. And poor outcome was reported in very small case series from China, and we can ask ourselves what was the experience of this center. And clearly, they report 0 survivors in this large series of ARDS patients. In this meta-analysis published in Journal of Critical Care in 2020, you see that 94% mortality was reported when ECMO was used for COVID-19. Another explanation for VV ECMO use was the rush to public case series with intense competition, nice competition, but still a competition between centers to publish case series. And it was a rush to publish case series with very short follow-up, and at the end with a very uninformative message. And just a few examples, this study was published about 32 patients on ECMO, quite a large number of patients, but this study was published after 24 days on ECMO. So clearly very early outcome, 31% mortality, but at the end of the follow-up, 53% patients still on ECMO. So clearly it's totally uninformative, and it was very difficult to raise any strong conclusion. And at the end, when you pull early on a meta-analysis, when you try to do a meta-analysis on the ECMO used during the pandemic, you have this neutral signal without any strong conclusion about efficiency or futility. What we did in our center, so a large center, we wait a little bit. We try to do what we know to do. So we did ECMO by application, a strict application of the EOLIA criteria, and we use prone positioning before ECMO cannulation. It was highly recommended, and clearly when you perform ECMO like that, you see this publication in the Blue Journal showing that mortality at 60 days, if you have a longer follow-up, you find that 35% of this patient died, which is quite an acceptable mortality for this severe patient. And this is the recent publication of our center showing that with a very severe patient, when you have a longer follow-up, when you strictly apply EOLIA criteria with very frequent use of prone positioning before ECMO, you see that you end up with a mortality at 31% at day 60. If you go further in the follow-up, you go until day 19, you find a 36% mortality, which is quite similar to what was shown in the EOLIA trial. So clearly, VV ECMO has been underused during the first months of the pandemic. At the end, when you have a long follow-up, you see in quite experienced center, you see that VV ECMO indication should not differ between COVID-19 patient and other patients with severe ARDS. You need to be prepared because it's going to be very long ICU and hospital stays. So clearly, there is a key role of the experience and the preparedness of the team. So survival of this patient is similar to that reported in studies on ECMO support for severe ARDS published in the past few years. It should be considered at early stage for patients developing profound respiratory failure and despite optimized conventional care, including prone positioning. So if the second wave occurs, clearly we should use ECMO, and we have to have a long follow-up to evaluate the efficiency of the disease. And by using too short follow-up, too early follow-up, clearly you will convey a wrong message. So we are waiting for a result coming from large database, which will use 60-day outcome, and to see if the outcome of this patient is good, like we previously published. Thank you very much.